advances that one? Yeah. Good afternoon. It's good Franz scheduled me this early in the afternoon to speak because I've been up all night coming over on the plane, so I hope I won't nod out on the podium. Franz and I talked about the PLCO recommendations, and he was somewhat upset by them, said how impossibly, excuse me, the U.S. I'm sorry, you see I'm already tired. The U.S. Preventive Services Task Force recommendations we talked about in October, and Franz asked me how on earth could they possibly come out with such a recommendation in view of the ERSPC studies, etc. And I said, wait a minute, there is an explanation, and I want you all to think for a second. This is the U.S. Preventive Services Task Force. This is a U.S. perspective. This is a government agency looking at the concept of population-based testing. Notice all the comments earlier on, Jonas has said, and Jerry Andrew is talking about the difference between population-based testing, opportunistic testing, and an individual man's right to get a PSA. These are all very different uses of screening. Where the U.S. Preventive Services Task Force is coming from is, should the U.S. government be spending money in a program to prevent prostate cancer testing? And those of you who don't live in the U.S. right now don't recognize that the fiscal crisis in the U.S. is growing rapidly, and Medicare is rapidly coming in the crosshairs because we can no longer afford our healthcare system. And unfortunately, preventive services at all things, not just prostate, but breast, colon, and many other preventive services are being seriously questioned, and the U.S. Preventive Services Task Force was to ask that question as a recommendation of the U.S. government, should we be doing this? You have to put that hat on to begin to understand where their recommendation is coming from. So this was the report. It's actually a draft that was issued in October. The final report is still pending. And there are a lot of American urologists who are testifying in Congress. I know urologists have lobbied the New Jersey state legislature to basically come out with statements against the U.S. Preventive Services Task Force. I'm mentioning this because this is as much a political document as it is a scientific document. And again, you have to understand that concept. The immediate reaction that came out was the New York Times, of course, did the sound bite, and this is the sound bite. And I'm not so sure that that is the conclusion, even of the task force, because it's a more nuanced thing. And I think ultimately we are going to get to the end point that Jonas very nicely talked about. It's not a matter of if, it's when and how. What did the U.S. Preventive Services Task Force? They asked 4 specific questions. Does PSA-based screening, and they meant population-based screening, decrease prostate cancer mortality or all-cause mortality? Yes, they looked at all-cause mortality. That was one of their mandates. They also looked at what are the harms of PSA-based screening for prostate cancer, what are the benefits of treatment of early-stage or screen-detected prostate cancer, and what are the harms of treatment of early-stage or screen-detected disease. In other words, a classic, what are the benefits, what are the harms? And again, the mandate of the U.S. Preventive Services Task Force is not to seek opinion. This is evidence-based medicine. So they are mandated to go back to the literature and seek the literature only to make the recommendation. They don't ask Franz what his opinion is. They don't ask Jonas what his opinion is. They only go to the literature and what's reported in the literature. So the first question, does PSA screening decrease prostate cancer mortality or all-cause mortality? They looked at actually about 7 or 8 trials. Jonas described them in his earlier trial, but I think they really focus on, I'd like to focus on these 3 because I think they're the ones that have gotten most of the attention. 2 of them have been updated since the U.S. Preventative Task Force. I'm showing them as they are in fact reported. And we all just heard Jerry talk very eloquently about the PLCO trial and the conclusion here. We know about the ERSPC trial. Jonas just updated us on the current article. And I think this is the graph most of us are very familiar with. But I want to focus on a concept that it's after 8.8 years of follow-up. We were dealing with a fairly large sample size of 162,000 men. But as Jonas pointed out, the absolute number of men is quite small who actually develop prostate cancer. And when, in fact, the U.S. Preventative Task Force looks at this, they're saying they're not so much interested in relative risk reduction, which is what a screening trialist is interested in, and what we as urologists are interested in. They are as much interested in absolute reductions for a population. So it troubles them when they say from all deaths from any cause is virtually no difference. And as Jonas eloquently pointed out, you would need a sample size of I don't know how many millions to even begin to detect this statistically. So the population of ERSPC is grossly underpowered to detect an all-cause mortality difference. But from the U.S. Preventative Task Force, they're saying, wait a second, how many men do we have to screen and treat before we see any difference between how men live longer? And probably the most important thing to understand, and this is based on the first trial, when we look at what was the difference in the ERSPC trial between the control and the screened arm, I'm presenting the data in a slightly different way. If you look at the number of Gleason 2 through 6 cancers and the number of Gleason 7 through 10 cancers, you'll notice between the two arms, between the screen and the controlled, there's not much difference in the high-grade cancers. There's an enormous difference in the low-grade cancers. And I think many urologists in the audience are beginning to be troubled by how many low-grade cancers we have to treat to prevent those deaths. More importantly, in absolute terms, this is the difference after 8.8 years. This is what someone who's running the Medicare budget is looking at and saying, well, that's an absolute risk reduction of 20%. That sounds huge, but in relative terms, that sounds huge, but in absolute terms, the number of men we're actually preventing from dying from prostate cancer is remarkably small. Again, Sweden is different. Sweden is driving the ERSPC results, which is interesting because Finland contributed virtually half the patients. So there's something, I'll use an American term, funky going on about these trials because there's something different here. And I also want to focus on the absolute number of deaths in the US PLCO trial, which is extraordinarily small. Again, the US Preventative Task Force looked at all these numbers, and they were impressed about this. And again, their focus was US Preventative Task Force is focusing not just on all men, but especially on men in the US, and that's a different population from Sweden. As you said, if you took Sweden out of the original study, the ERSPC would have been negative back then. Is that still true, Jonas, if you take it out?
No.
So now it's positive because of the Netherlands is beginning to kick in some of the power.
Exactly.
So, but remember, the ERSPC trial did not have today's publication to them. They looked at the data as it existed back when they did their report 2 years ago. And they noticed if you took Sweden out, the trial would become non-significant, and the vast majority of patients contributed were from Finland. What made Sweden different? Well, they were screening twice as frequently as everyone else. You could argue the PLCO screened 4 times as frequently as everyone else. And more importantly, the number of deaths from prostate cancer was unusually high in Sweden. Is there something going on in Sweden or the Swedish water that makes it different from the American water? I don't know, but precisely because you have more deaths from prostate cancer, from a public health perspective, there's getting more attention. When there are fewer deaths, and I'm talking in relative terms and absolute terms, all of a sudden the impact of implementing PSA testing from a population base becomes more problematic. Again, this was my comment about the total number of cancers diagnosed. So let's focus on the most recent trial that was published as of today. I'll call it your trial. It's the Hugesen trial, not the Göteborg trial. Again, when we look in absolute terms, yes, there is a difference. It's almost a 50% reduction in relative terms, but in absolute terms, you're finding many more Gleason 6 tumors, not many more differences in the higher grade tumors. It gets to the heart of which of the cancers truly kill you. And in absolute terms, again, after 14 years of screening, from a population basis, in an absolute term, these are the differences. And notice 0.7 is about twice 0.4, but from a public health perspective, they're going, this isn't involving a lot of patients, and it's costing a bloody fortune. Okay? And that, I would argue, is the problem. This is a political problem for urologists. Because if we don't begin to counter the gross overdiagnosis and inappropriate treatment, the privilege of doing this will be taken away from American urologists, and I trust you, if it's taken away from American urologists, it might be taken away from all the urologists, because this is a major public health crisis. We are in a crossroads where the cost of taking care of diseases as a whole, but especially cancers, has come to the extraordinary attention of most healthcare funders. Let's go farther, because there's some more problems. What are the harms of PSA-based screening? This is what they listed in the report. I think most of us would argue, well, so what? So you do a biopsy, it doesn't show any cancer. What's the big deal? Well, from the public health perspective it is a big deal. It costs money and risks infection. 12% of the men received at least one false positive, resulting in additional rounds of treatment. Again, what's the problem? We're introducing costs and we're introducing potential downside. They were worried about fever post-biopsy. Most of us go, it's nothing. But wait a second, all you need is several hospitalizations, and again, the cost to society and the healthcare system goes up. And the question, what is it balanced by? Because we just looked at the mortality reductions were pretty modest with the experience of retention and hospitalization. This was listed directly from the report. Then there's another troubling portion. What are the benefits of treatment of early stage disease? Again, these are evidence-based people. And when you go back to the evidence, again, the Swedes tend to be out in the front. And when you look at it, there's fundamentally only one randomized trial supporting the benefit of one of their major interventions, i.e. surgery. And when you look at that detail, they say, well, wait a second, this surgery only works for men less than age 65. Well, this is troubling news to the U.S. Preventive Services Task Force, because they're saying, wait a second, there's clearly no benefit from a mortality point of view, and your treatment doesn't seem to have any evidence behind it. How can we in good conscience say that there's evidence to support a screening and treatment program? Because screening only makes sense if you have an effective treatment. As far as the U.S. Preventive Task Force is concerned, they're concerned about our data for treatment. Again, I'm pointing out the over 65 group. We do have, again, from Sweden, the one trial that supports the efficacy of radiation therapy. Again, after 10 years, there is a difference. Again, that relative reduction that we're so proud of, but in absolute terms, it's again fairly modest. This is where the U.S. Preventive Services Task Force is coming from. What are the harms of early treatment? I think everybody knows the quality of life issues. I just post John Way's graphs here, but I think everybody knows that treatment, surgery certainly can result in incontinence, impotence. I'm sure it never happens in the crowd in this room, but when the epidemiologists look at this problem, it is more prevalent than we'd all like to see. How is screening being implemented? Which is another concern of a U.S. Preventive Services Task Force. They could even take the next step saying, well, there's no evidence that benefits it within the 10-year horizon where we have data. But in fact, where is most of the screening happening? This is where the ERPC trials theoretically validated screening, but in the U.S., most of the screening is happening farther downstream among the older men. So again, when the U.S. Preventive Services Task Force is saying, how is PSA testing being implemented? They're saying, this is nuts. It's happening in the very men who probably have a less than 10 to 15-year life expectancy, which are the very men we've demonstrated from screening trials are not likely to benefit from screening. So again, this is a problem. Just turn a comment again on the U.S. population. As you know, I've been very interested in this whole issue of trade-off of death from cancer versus other causes. But fundamentally, the disease in the U.S. has changed. Because of opportunistic screening that's been going on for over a decade, we have effectively moved the date of diagnosis up by essentially 10 years. So when you look at men aged 70 to 75 and greater than 80, the likelihood of dying from this disease, if left untreated, is fairly modest. This cries for a randomized trial. The good news is the Brits, as far as the PROTECT trial, will have answers to some of these questions in 3 or 4 years, but you better hope the PROTECT trial is positive, because if it's negative, urologists are in major trouble. Again, these were T1C disease from the SEER data. So let me conclude what the U.S. Preventive Services Task Force is saying. PSA-based screening results in a small, they didn't say no, they said a small or no reduction in prostate cancer-specific mortality, and is associated with harms related to subsequent evaluation and treatment, some of which may be unnecessary. This is the exact wording they had. So they didn't say screening doesn't work, but they're saying how it's practically playing out is most of the guys who are getting tested, it's not likely to benefit. For you who are appropriately benefit, the benefit is small, and by the way, the collateral damage is fairly high. So in my mind, the take-home message is population-based testing from a political point of view remains controversial. We have to change the way they do them. How did you phrase it? It's not a matter if, but how and when. The whole algorithm, and I think the whole rest of this conference is focusing on that algorithm and different techniques of falling from PSA testing instead of straight biopsy. Maybe we're doing imaging, maybe we're going elsewhere. But what we're doing right now is economically not sustainable, and from a public health perspective is not appropriate. For men over 70, and we can argue 75 because there truly is a healthy bias, a healthy 70-year-old, I would argue, probably will benefit as an individual. From a population base, remember, if you're implementing this from a population base the way they're doing in Göteborg, everybody above age 70, you'd stop from a public benefit point of view. Again, put the mind cap. The U.S. Preventive Services Task Force isn't saying that a 75-year-old can't go off and get PSA testing. That's not the discussion. Discussion is, should Medicare pay for that PSA test? Should Medicare pay for the ultrasound? Should Medicare pay for the robotic-assisted prostatectomy? That's the question, because if a patient wants to pay for it himself, that's not part of the discussion. This is what this crisis is all about, because it's asking society to pay for all these screening and treatment. What the people outside of this room and outside of the healthcare profession are asking some tough questions of us. If screening proves to be more beneficial with longer follow-up, and I suspect it will, and I think Jonas and Jerry both agree with that, it'll probably benefit those in their 50s and 60s. And that's, in fact, where we probably should be concentrating. And that, in fact, is the message we have to take back to the public health folks is don't toss this all out just yet. Wait 4 or 5 more years for these studies to accrue, because I think we have something here. But as urologists, at least US urologists, we have to stop treating and radiating the 85-year-old guys, because, quite frankly, in the US, that is big business. And that's what the U.S. Preventive Services Task Force is questioning. So thank you very much. Franz will now tell me why I'm all wrong.
Thank you very much. It was an excellent talk. I personally believe strongly that it's important that we realize as urologists that this is mainly a political question, because we tend to believe it's a scientific question. We discuss about numbers, and if you're not aware that that is basically the public health, then we might lose. You might not, or maybe you know that in Switzerland there is something similar that's called the medical board, and they did issue not a draft recommendation, but they did issue a recommendation against PSA population-based screening. So they went even further. They didn't publish the draft recommendation as the U.S. Preventive Task Force.